So we do have lots of patients now, as you point out, that are into second and now third line. They've still got oxyzacard. They might have arizacard. They may even still have some biologics. And now we have two new medicines, oral therapies. They're a little different than all the other drugs, although they're cousins in some way of the other drugs as well. Axel, I'll start with you on the Stivarga side, the regorafenib side. So, this is a drug that's gaining in use and recognition and understanding how to use it, but also has kind of some issues that our community partners have with it. So remind us quickly about the study and some of the insights you have a year later of use.
Yeah. So, the study, the correct study which brought us regorafenib was a study that targeted an unmet need patient population that went through all these different lines of therapy that we talked about, had run out of treatment options. So had bevacizumab, EGF receptor antibody, if KRAS wild type at that point, 5-FU, oxaliplatin, and irinotecan, and was still in good performance status. And these patients exist, actually, they exist a lot. So these patients were randomized 2-to-1 to regorafenib or placebo in an international study. Hazard ratio of 0.77 for the overall patient population means a 23% reduction of death events. The study is kind of delays tumor progression, about 50% of patients at the first scan. That's where the shape of the curve, the progression-free survival curve comes from. So it's an active agent. No one disputes it's an active agent. If you talk about hazard ratios, actually compares, what do you say, favorably to other studies which we consider for granted. Now the problem with this drug, of course, are side effects, that come early, invisible, and let's say side effects that are kind of affect quality of life potentially, blisters on feet, hand-foot skin reaction, inflammatory skin reaction, etc., fatigue. I do believe there's a difference for a patient whether you have an asymptomatic neutropenia or something that really affects their ability to walk. Now, these side effects come early, and what we've learned over the last years that we have to pay very close attention to the first 2-3 weeks on therapy and probably have to diverge away from the high starting dose, which 160 milligrams, use a lower dose. And there are studies ongoing that try to address this in a more strategic manner and controlled manner. And I believe, the way we handle regorafenib at Mayo Clinic, most patients actually can tolerate it. Most patients, if you know what you're doing, you preemptive, let's say, skin management, etc., can be kept until the first scan, and then you decide whether it's worthwhile for patients to continue or not. So I think it adds to our repertoire of agents that we have. Is it a home run slam dunk? No, it's not. And I strongly believe not every patient needs regorafenib. Patients in PS2 or 3 or 4, this is not a drug that can pull you away from a deathbed.
Right. It's not a pre-hospice drug.
No.
So you need that good PS.
You need the patient population in the study, good PS patient who knows how to handle and communicate side effects.
You and I have busy phase 1 units. I think everybody here does. So why are we leaving overall survival on the table and switching? We often will go to trials first and that kind of thing. Should we be pulling this drug into that earlier setting?
I think this is to get back to the original point of what does this benefit mean to you? Mm-hmm. And I think some people will say the median benefit, there aren't a lot of dramatic, there's a 1% response rate. There are not a lot of people who get long-term benefit from regorafenib. Cancer is tough, and I think the benefit should not be dismissed. On the other hand, for that magnitude of benefit, some people would, an option to try some therapy that may have more upside, is appropriate. Particularly for patients who will be well enough that if they progress, can go back to rego if they have, after they've tried a trial.
So don't leave the survival on the table. Manage the toxicity, dose and schedule. We're learning as we go, and monitor patients. Dan, 5-FU is alive and well. So we have a new medicine, which is not really 5-FU, but it's certainly in that class. It'll be in that class in TAS-102. Tell us about the study and our expectations of how this medicine is going to come into play over the next year or so in the United States.
Well, the study design is pretty much like the correct study. In fact, I think they're almost identical.
They copied a lot.
Yes, it was a copy. So the study results look pretty much the same, and I think with a somewhat lower toxicity profile. Mm-hmm. So I think, again, choices. People are going to have choices now to make between this drug, assuming it gets approved in the United States, which I think it probably will, of sequencing, of which drug do you use first. I think right now I'm thinking that TAS-102 may be a better first choice. It depends on the patient and how good they are at managing symptoms and how good your nurses are at managing patients.
Has any one of us given a dose?
Not yet.
So I haven't
Not
yet.
yet.
Yeah, but it's
I know
interesting.
the data very
Everyone
well
you
myself.
talk to, I mean, the one thing is it's an oral fluoropyrimidine, a fluorothiamidine actually,
Yes.
and has no hand-foot syndrome.
It's a more myelosuppressive.
More myelosuppressive in the last line setting,
Yeah,
you know. And I actually can see that TAS-102, I mean, right now we're looking at the data, single agent, salvage therapy against placebo. That could be an ideal combination
be
partner for
upfront.
earlier lines of
Yes.
therapy, maintenance therapy. I mean, you can see all the trials. I mean, the problem is it's not going to be as, let's say, sexy because it's an oral chemotherapy drug, not the targeted biologic
But it might be
agent.
more in our comfort zone,
But
too.
it's actually, I think it's an unmet need for patients, you know, get away from hand-foot syndrome, for instance, less diarrhea. I think it could be
It could settle the
replacing-
argument between capecitabine and an infusion.
Exactly. You just, I mean, the dosing, I have to keep in mind what the dosing is. 5 days, 2 weeks in a row, and then a 2-week break. So patients are in a 28-day window, they're on the drug for 10 days.
Yeah, but we'll fiddle with that. Don't worry. We'll fix that. Don't worry.
I think that this is not trivial though. So just because it's oral doesn't mean it's easy or simple. And from a compliance point of view, I'm getting a little nervous around how much time I'm going to have to worry about. 5 days on, 2 days off, 5 days on, 2 days off, 14 days off, when I'm going to call. And I think the same around regorafenib, where you have to be in touch with, you can't put people on autopilot. And I think one caveat on the TAS-102 data is, a 30%-ish grade 3-4 neutropenia, of which there was a 4% risk of febrile neutropenia. And I think this issue around the compliance, whether you want or need to check how to deal with particularly patients with lesser performance status, I think are one of the important details presumably when the drug becomes available.
Okay, I got to wrap us up, guys.